All right, we're going to get going with our panel discussion. So we can see some user-centered design in action by researchers here at UW-Madison. Just a couple of quick notes. We're going to have Aaron, similar to this morning, Dr. Proctor and Dr. Lyon will be discussants, and we'll have an opportunity to ask questions during the Q&A session after we hear from both groups of presenters. And our first panelists will be Dr. Olayinka Shiyanbola and Dr. Susan Passmore. So pass it over.
We'll see. Okay, good afternoon, everyone. Thank you all for being here today and listening to us talk today. Dr. Passmore and I are going to talk about a project that we did in how we might improve the reach of diabetes self-management education among African Americans or Blacks, depending on how you self-identify in the state of Wisconsin. Oh, and it doesn't move. Okay. So to give you a little bit of a background and context, for patients with diabetes, we know that diabetes self-management education is important. We have programs that allow these patients know how to manage their diabetes, how to take control of their disease, and also how to live longer, healthier lives. Now, these diabetes self-management educations in general have been shown to be cost-effective. However, something that we've seen is that a lot of these programs, communities of color remain underrepresented in actually participating in these programs. Now, thinking about the state of Wisconsin specifically, we do have an example of an evidence-based diabetes self-management program called Healthy Living with Diabetes. It's evidence-based, it's already been endorsed by the American Diabetes Association, already endorsed by the CDC, and it has also shown improved outcomes. It has been shown to not just improve A1C and also to increase self-efficacy, but it has also been shown to actually be cost-effective as well. However, similar to the general diabetes self-management program, again, African Americans do have challenges when it comes to participating in this program. So our gap was trying to understand what are some of the barriers to why African Americans don't participate in diabetes self-management education. And both from the provider side, the patient side, and an organizational side, what are those barriers? And then try to co-design an intervention with trusted messengers in the community. So these were the collaborators that we worked with. I'm going to talk about this project as a client team. We worked together with students who were in the Masters of Science in Design and Innovation program at the School of Human Ecology at UW here. And we were in client team where we were presenting our project to them, and they were helping us in the design and prototyping. So I want to acknowledge Michelle Kwasny, who was the founding academic director who actually led the students in this. Our other collaborators was CAN, which is the Wisconsin Institute for Healthy Aging, is the purveyor for healthy living with diabetes in the state. Unite Wisconsin is a community organization that serves African American communities, and then ICTR and the DNI Launchpad. So we had several diverse stakeholders. We had the users, which in this case are the African Americans who had participated in the program and who might consider doing it in the future as well. So they had to have type 2 diabetes. We also had healthcare providers who care for these individuals. We had community partners who were trusted messengers in the community. And then we had organizational leaders who had conducted the program in the past or who might think of doing the program in the future. So how did we incorporate our women-centered design? I want to quickly acknowledge that because we were working with students, they were actually split into 4 different teams. And the team that we eventually went with their prototype and idea is the community team, which is represented right here. And I want to acknowledge the students that we went with their prototype. So these were the different phases they went through. First of all, the inspiration stages. which is where we had a looking in stage where the students were actually doing research and actually talking to us as project partners about what exactly is diabetes and understanding the problem from our own viewpoint. So Dr. Passmore and I, we met with the students, we talked about it and about community engagement. Then they had a looking out phase where they actually now started doing field research and doing interviews. They had a looking around where they were also getting inspiration from other areas of research outside of the people they were talking to. They did what they call research activity debriefs, and I'll tell you a little bit about what that means in a little bit. They looked at themes, then they started thinking about what is feasible, what is viable, and what might actually work for the population we are working with. And then they presented the opportunities to us as the client team. Then in the design stages, that is where the ideation starts coming in. And they were developing their ideas, they were brainstorming, and then coming up with different prototypes, low fidelity prototypes at the beginning before they eventually ended up with high fidelity prototypes. So what I'm going to show you right here is an example of some of the ways the baseball, they call them baseball cards. And this was a way of evoking empathy from the user's perspective of what it actually means to have diabetes. So this is an example of Mary Kate, of course, a fake name. And they actually went through the process of getting all that information and trying to distill that information to understand from her, what does it mean to actually have diabetes? What are the tensions about doing the program? Now, some of the methods, like I said, is they did those interviews, right? These were all the people they talked to, the participants, those who facilitated the program, people who were looking to be in the program, and they used these baseball cards to actually develop these key personas, like I said, around the stakeholders' perspective of what it means to actually live with diabetes and understand their needs. This baseball card is another example of creating another user story on the facilitator end. So they created all these different profiles for the different people that they actually interviewed. And like I said, this is the point of getting into the mind of the user and trying to understand their perspective. They did desktop research, which is they actually look through the guidebook that the facilitator uses in actually organizing the program, the content, to also look at that from their perspective as well. They looked at other diabetes self-management programs outside the state of Wisconsin, how it affects patients' lives. Something that was also very critical that they did, which is a very important perspective that we got in the women-centered design, is evoking empathy and also getting into the emotion. And they did that not just with the baseball cards, but also doing what they call the experiential journey mapping. They took time to say, I want to actually see what it looks like to actually draw a serving, do portion control like a patient with diabetes, eat like a patient with diabetes for a week. And the whole point of doing this is that inspiration stage of just trying to get into that empathy of what it means to live with diabetes. So what did the students find? In terms of the analysis on the organization side, they found that there were issues with the referral system as a barrier to why African Americans were not participating in the program. On the provider side, the doctors were saying, well, we don't have time to talk about diabetes management programs, and they were leaving all of that to the nurses. On the content side, there's a script for it, it's too scripted, and they have to read to the patient, which they told us was a barrier as well. And then the facilitators just don't have time to engage, use cultural relevance, and actually talk about how to actually engage with African Americans in the program. Now, something that was very critical that they did as well is identify pain points. Now, pain points are basically mapping out from the moment that patient gets diagnosed with diabetes to the point where they actually attend their first workshop. What is that process? What happens? Where are the points where there might be gaps in the system that might be an hindrance to why they don't participate in the program? And this was used as sort of a guardrail and to sort of allow them also design a solution that are actually addressing those different pain points. So there were 5 pain points that were identified. First of all, if you see right here, the pain point 1, the PCP's primary care provider said, well, we run our diagnosis, but we don't have guidance for what programs are available. We don't know about healthy living with diabetes, and there is no one to actually give us guidance on how to refer people to the program. Pain point 2, you see that even if a patient or a person said, I'm going to self-refer myself, you know what, I'm going to go on the website and I'm going to go see if I can actually join a program. Well, the referral system and the data collection system on the website is currently not optimized to be able to capture that information and actually refer them to an actual program. Then pain point 3, you see also the diabetes educators. They are saying, well, we don't know much about the program. No referrals are coming to us and we don't have information. And so there's low awareness about the program as well. Then pain point 4 and 5 are so related to each other, which is that the program leaders are saying, look, you know what, we don't have capacity. As a facilitator, I am overwhelmed. I have to recruit people into the program. I have to get resources. I have to find a way to get them to the location. There's transportation issues. And so all of these pain points were identified at the different stages of actually getting to a workshop that could then help us think about what are some of the solutions to address these different barriers and problems.
So I'm going to take us through, we've talked a lot about how the students went from the problem stage and now talk a little bit about solutions. So for each of the pain points, they developed a very broad opportunity. So for example, create resources to connect healthcare educators to healthy living with diabetes to increase referrals to patients. Addressed pain points 2 and 4, right? Build a network of diabetes nurse educators and health care providers who refer patients to the program. That's pain point 2, 3, and 4. So each of the pain points were addressed in their solutions. And then, or their opportunities, we're not quite to solutions yet. And then they went through on the bottom right-hand side, there's a little chart where we have impact up and down and then across resources. And then they chose the solution that, or the opportunity that had the highest impact using the lowest resources. So opportunity area 2 was the choice. But still, we haven't quite gotten to what does that mean, engage and inform diabetes educator, right? We still have an opportunity maybe to do a portal or network or a system. So we know that there was inspiration that came from the interviews, but we still quite haven't got to the solution. So from this point, they went back. They had some ideas and went back to their stakeholders and talked about the possibility of some of the solutions that they developed. One being holding a seminar workshop, which stakeholders said, you know, that's not going to work for us. That's too time intensive. And maybe we would only want to go once and not every year. Number 2 was to develop a newsletter, which again, labor intensive and maybe not getting the message out. And then to develop a website and print resources for providers to work with patients with. And so what the team decided to do was to integrate those two and develop a website referral system. So there's a little glimpse at the website that they developed and how they would kind of facilitate the provider being able to refer the patient. And here are some personalized resources that I developed. So this is something that a provider can print out for the patient, which will be personalized to them, giving them information that's relevant to them, but also, and potentially facilitating a dialogue, right? Let's look at this together and have a discussion. But then finally at the end, you'll see that there are, well, it's blank right now, but the workshops would automatically fill in that were in their neighborhood and closest, the most convenient to them. So even if the provider didn't get to that, the patient's still walking away with that information about workshops.
Okay, so next steps quickly is now we are planning to apply for funding to now test the chosen prototype that we picked, which is community team. And we have conceptualized this as Refer Connect based on what we learned from this design thinking project. And our aim is, first of all, to evaluate the feasibility and acceptability of our Refer Connect strategies. And now we want to start thinking about diverse stakeholders. We've got that inspiration from the users, but now start thinking about healthcare providers and payers and insurance and other organizational stakeholders as well. And then implement it and test for effectiveness as well in increasing both reach and adoption by providers. Okay, and so we just want to acknowledge the students at the Masters of Science in Design and Innovation that we worked with. And this is their picture. They worked with us in developing this project, and just want to say thank you on their behalf as well. Thank you.
All right, thank you for that. And so our next group consists of Dr. Stephen Kilgus, Dr. Katie Eklund, and Dr. Andy Garbacz. And hopefully you can get that switched up.
All right, wonderful. Thank you everyone for joining us. My name is Dr. Katie Eklund. I'm an associate professor in the Department of Educational Psychology here at UW in the School of Education, joined by my colleagues, Andy Garbacz and Steve Kilgus, also both associate professors in the Educational Psych Department. And then the three of us together co-direct the School Mental Health Collaborative. We're excited to be here today to share with you more information about our project on optimizing the capacity of public schools to promote youth mental health. We also would like to acknowledge that funding from this project was provided by the UW Institute for Clinical and Translational Research. Like it is turning up there and not down here, so just a second.
Oh, so strange. It's not. We're just going to start again.
Yeah, that's fine. Thank you. Perfect. There we go. All right. I think we're back in action here. Wonderful. So on our research team, we talk a lot about this 2020 phenomena, that 20% of kids have some type of mental health concern, warranting help and support throughout their school trajectory. However, only 20% of that group actually receive help and support for their concerns. So there's a large gap between kids who actually need services and those who receive them. We know that the pandemic further eroded the crisis in the US around youth mental health, and that it's been declared a national emergency by the American Academy of Pediatrics. We also know that when children need mental health support, they are most likely to seek it out and or receive it in public schools. We also know mental health needs disproportionately impact minoritized youth, and that there are outcome disparities, as we've talked about today, around race and ethnicity. Certainly, if we're going to be able to address the needs of children's mental health needs, it's important that we include families, youth, and school professionals as collaborators in the development and implementation of this work. A parent we worked with recently provides evidence of how community participation and voice is essential to this work. So this parent said to us, parents should be asked to be a part of the decision-making process at a school and be given access to school-wide data. For me, that's especially important because I have a Black daughter. I think some of the punishments I've seen at our school have been really punitive, especially to minority children. So the current project that we worked on over the past year and a half centers the voice and perspectives of family members, mental health professionals, educators, and researchers to be able to develop a framework for optimizing school mental health that emphasizes equity and embeds anti-racist practices. As part of this work, we recruited family members, mental health professionals, educators, and researchers who provide and/or receive mental health support themselves, but rarely have a voice in the design and delivery of what school mental health services looks like. We developed key partnerships with the community advisors on research design and strategies, cards through the Wisconsin Network for Research Support, which was an amazing group to work with and is here in the audience today. But the experience with cards was honestly a wonderful formative part of my professional career, and really, I think, just offered a great opportunity and insight into how to make this work better. We also developed collaborations with family advocacy organizations, youth serving organizations, schools, and community mental health centers to be able to cast a wide net of potential participants. We facilitated connections to organizations and individuals through these different connections that weren't originally a part of our design, but found individuals who had a lot to tell us and a lot to share regarding the questions we should be asking and aspects of this research that we hadn't originally considered. These leaders assisted us with a co-design process and suggested changes that really improved data collection and integration. So I'm going to turn it over to Andy to tell you a little bit more about what that looked like.
Great, thank you, Katie, and thanks everyone for being here today. So I'm going to share just a little bit about some of the methods that we used. As Katie mentioned, we worked very closely with family and youth serving organizations as well as our school district collaborators. These individuals were really central to the co-design process, both in terms of the development of the process, the materials that we used, as well, of course, of the findings that I'll review in a few minutes. We worked with mental health professionals, teachers, researchers, and family members. These individuals included many different roles in schools and community organizations that you could see listed here. Our co-design or design-based process included 3 steps. First, we worked on a needs assessment. We worked with all the individuals that I just mentioned in different groups to better understand their experiences and their perspectives and their ideas for how school mental health services should be modified, revised, or changed. Then we engaged in an initial development process where we worked as part of these teams to develop the core features of what they suggested should be included in the process. So I'll be reviewing here today some of the core features that came out of those discussions. Then the final stage was to go through an iterative refinement process within focus groups that used a procedure called nominal group decision making, which essentially involved us asking a series of questions among our groups and then guiding that process towards reducing the number of features or elements to a core set that the individuals involved in each of those teams felt was most important. We really focused on using a critical approach to thematic analysis as we reviewed responses that provided sort of a dual purpose for us and our team. The first was to constantly consider our positionality, our kind of ideological background and social identities, while at the same time considering the feedback and the findings that the individuals were sharing with us relative to the structural inequalities, the power ideologies, and the hierarchies that existed in schools and community settings. So the findings from this project centered on 3 main categories. I'll review these in turn briefly here today. Glad to talk in more detail about what these involved. In terms of school practices, some of the main findings included addressing bias and white-centeredness in school policies and practices, integrating mental health support across classroom and non-classroom settings, and really including family members and youth as part of a participatory process on school teams and in school decision-making. There was also acknowledgement that additional training was needed for school professionals in 2 or 3 kind of primary areas. One was specifically around mental health support. The second was on social justice, including training and support around partnering or working more directly with families. And then finally, some support around aligning and integrating some of these practices or features within existing initiatives. The third set of findings pertain to family, school, and community partnerships. This included kind of that final bullet point that I reviewed relative to school practices, which was seeking out and including family and student voice in decisions that the school was making. And in that process, lifting up families as leaders in school systems to provide feedback, guidance, and to lead that process over time. It also included creating systems that promoted family-to-family connections, establishing a more enhanced community within school settings that allowed for individuals to work for and with one another. I'll turn it over to Steve now to talk about some of the implications.
Thanks both my colleagues for getting us this far. So yeah, some implications from our study. I think we found rather interestingly and thankfully that we could, in working with these various groups, that they were able to provide feedback that led to us be able to construct a new framework for supporting school mental health that would center equity within the process. I think it was really interesting in that we found that folks were very willing to provide this feedback and that they often didn't feel as though they were part of this. I think about the kind of initial framework process. As researchers, we often think, well, let's build our logic model. Let's review the research. Let's think about what is all that's out there. We'll do the initial work and then we'll work with others on the design process. I think our goal from even the early stages in the conceptualization process was bringing folks in and getting their perspectives to even like at that very foundational stage in building into their perspectives and helping us to build out that framework. A goal of this was also not to think about how we as folks who were used to working with schools could center this work within schools, but then also provide information that would help with connections from the school to the community, right out to where parents are, to where other community members are, to understand how we can bring them into the school setting to support student mental health, but then also how we can pull in the resources that exist within a community to make sure that they're coexisting and interacting well between the school and the community to make sure that there's a broader approach to supporting student mental health. Skipped one. As I mentioned, many of the folks we interacted with were very excited to provide us information. I think back to, when we talk about this often, some teachers that we talked with at one school, they're like, we keep hearing how important mental health is, that we should be doing more to support our kids. And then when I go to ask a counselor about, hey, can you tell me a little bit more about what's going on with this kid and how I can better support them? Like, well, there's confidentiality issues and we really can't get into it. So they're hearing it's important, but they're also hearing they're not a part of it. Right. So our goal through this process, think about how can we better bring in teachers in the design process and think about how we're designing it for them in a way that makes them feel like they can be included and that they actually can be. We also found that the community connections with family serving organizations and equity-focused initiatives were pivotal in us getting to a point where we were able to access all the relevant individuals and all the relevant backgrounds that helped us really understand what we were building and making sure that it worked for a broad swath of individuals. So where do we go from here? This is very foundational stage. So our goal here is to think about all the various practices that need to be integrated into this framework and all the various implementation strategies that need to be integrated as well to ensure that those practices are being delivered with fidelity. And then also building towards eventually evaluating its impact, right, across a range of proximal and distal outcomes. A near-term goal is building out an R34 proposal that would allow us to continue to build out some of these materials and strategies and be able to do some initial feasibility and usability testing as well. And that's it. Thank you very much.
All right, we're going to invite our guest faculty to join the panel up in the front. And so we've got about half an hour to kind of discuss the work that was, all the great work that was shared here. And really wanted to start this off by giving Dr. Proctor and Dr. Line an opportunity to just kind of reflect upon what you heard shared from the panelists and any thoughts, suggestions, questions, feedback. So go ahead.
Well, thanks for another 2 great talks and projects, and it's fun to be able to learn what everyone's doing. and I think those are also sort of well placed after, I just had the opportunity to talk about human-centered design and get those creative juices flowing. And I think we saw lots of iteration and different ways to incorporate different human-centered design techniques. And I mean, some of the reflections that I have and the things that I noticed and that really resonated included, of course, bringing in people as early as possible, which is sort of, I think, a core tenet of human-centered design. Before you get too far down that path, before you devote more resources before, like prior to having the critical input that you're going to have, and to be able to develop these sort of multiple prototypes over time and get feedback about them. I also really appreciated the sort of specific personas developing as sort of like a key empathy tool, which they absolutely are, in order to really understand who your user groups are and how they, or subgroups and things like that, which we'll be having all of you kind of consider further as you do that activity, the sort of user identification activity that we'll be doing. Consider, like, if you have enough information or what other information you would need in order to develop something like a persona for any particular user, or at least any particular primary user that you might be identifying. I also thought that across these two presentations, we saw a bit of coverage across sort of both the dissemination and implementation spectrum, right? We sort of, the sort of targeted distribution of information, often sort of considered more of a dissemination sort of dissemination problem if people don't have that information available to them, and dissemination related solutions, but there were also sort of more maybe active implementation pieces of it that might be changing practice, and then developing a model that itself will need to be implemented once it's sort of fully fleshed out. And with each sort of component of that model and the practices, they may have sort of different degrees of usability ultimately, which could either be addressed or may need to be augmented with implementation strategies. So a lot of fun work ahead.
I want to add my admiration for two really important and innovative and well-designed projects. I loved the tools that your group developed. The baseball card was such an innovative idea and provided a very succinct way to try to capture the information. And then the tool that you developed that was the individualized carry forward plan. I saw reflected in that a lot of principles that I hear from health communication colleagues, that walking away with a personalized synthesis of the opportunities, the action plan. And then I really loved and would like to hear more about the response to, if it's relevant to the broader discussion, of what happens if you do nothing. And I wondered, I think we rarely use the stick, the carrot. We say, here are all the benefits. But if you don't do something, here's what's going to happen. And if our panel time allows, I'd love to hear a bit more about that. And then Katie, Steve, and Andy's group, the notion that people said, we're not used to having our input asked. First of all, I think that's important feedback and kind of a wake-up call. But I wondered, again, how relevant people believe their own perspective is, given that our healthcare systems are often very hierarchical. I remember working really hard to get my mother to even ask questions. If somebody had asked her what her preferences were, or how she would like care. And I've even had very well-informed colleagues say, I don't know, you tell me, you're the doctor. So a couple of points that I think are worth unpacking are the choice of the content, about here's what'll happen if you don't do anything, and the advantages and challenges of using that more in implementation. And then the comfort, the normative nature of asking people for input about their preferences for service delivery. I think those are a couple of important things that we could think more about in implementation.
Just a reminder to speak into the microphone for
I'm
the
sorry.
panelists so everyone can hear.
I'll try to do that.
I'm demonstrating for you.
Actually, I just want to add one thing on top of what Enola was saying, because the preference is both about service recipients, but also about other professionals in the setting, right? Which is, whether it's, you conceptualize them as a primary or secondary user group, but someone who has real influence in whether or not something's going to be successful and contextually appropriate, and is also going to be sort of a key leverage point for directing kids in, even if what happens in the actual service continues to be a little bit of an unfortunate black box for some of them, which it might continue to for some extent. Even, as you know, schools are near and dear to my heart, and sometimes there's a little overemphasis on that confidentiality that can wind up being a barrier to kind of enabling the entire system to be as responsive as it could be. And I know you're well aware of that, but just another great example of different users' voices and gathering that information in ways that can be quite helpful.
You want to reflect on any of the points raised by Dr. Proctor, Dr. Lyon?
Okay. I guess I could answer one of the questions and just correct me. Is this on? Okay, just making sure because I talk loud. So, there was a question you asked about what happens if nothing is done.
Right.
And when we came into this, I think we kind of understood the problem from the disparity angle. We knew that diabetes self-management education programs can actually help people live longer, healthier lives. But we saw that African Americans there was already a disparity when it comes to not just participating in the program, but it's even more important because there's already a high diagnosis of diabetes in that population. And there's also a lot of complications like stroke and blindness happening if they don't go to the program. So prior, we came in with understanding the problem on that angle of there is an equity issue. And we need to do something about it. We need to figure out solutions and address those barriers. And we need to co-design with the people. Because I think a lot of the times interventions are developed, but no one has actually taken a step back to say, why don't we co-design with the people that actually matter? Who's the people that the disparities are actually affecting, which is the African Americans and all the organizational leaders. And so I would say that it's a critical problem that needs to be addressed, and it's something that if we don't do something, we are going to have disparities be widened.
And I think that in terms of the carrot and the stick, it's a really interesting question because the stick is a stick, right? It's a threat. It's a threat, which is not necessarily going to be taken kindly, right? Not necessarily going to get the result that you want. But I think that's exactly where human-centered design helps so much, because you can make it so, hopefully, intervention that's so targeted to make the life easier of the user that it's just beneficial to them. If it's within their existing kind of benefit analysis, right? I'm going to do this because my life is easier if I do this. I'm going to print these materials so that I can have go through them and have a kind of guided conversation with the patient, rather than I'm just going to start talking to them. It's less, so if it's easier for them, they're going to, I guess that's more carrot. I think I came back to carrot.
And in particular, I was wondering about patient's response, that if I do nothing about my diabetes, I will go blind, or I will have a stroke, or I may lose a limb. The response of patients to that information or families?
So I think some of it was kind of captured in the baseball cards that we showed, because we asked them questions. I think the students were during the interview, like what happened at the point of diagnosis. And we had some of them reflect on that. Like I knew I needed to go to the class because I'd heard about some of the things that could happen if I don't go ahead and get some education about diabetes. However, I also want to acknowledge the fact that it's one thing to throw information sometimes at the community, and it's one thing to empower them to actually do the work. And I think this is the angle we're coming from, is that they might know all that information, but we need to provide a tool for them to actually be able to do something about it.
Okay, there it is. Just want to respond to, I think, one point about like to what extent did people feel like they could comment on, this. I think two things that came through, maybe three. One, we found some folks that I think were very much interested in kind of staying in their professional lane and saying like, I'm not going to tell you what everything should be, but I can tell you what I think would make my particular job easier. And then we would hear some kind of echoes of that in other meetings as well. But I also, even for some folks that didn't have ideas for what these solutions could be, they were really good at identifying the common problems that we were encountering that led us to think, well, that's now on us to think about what some of those solutions might be and thinking about what, get feedback on that in the future. Similar project to this that included similar focus group methodology, and on a similar but related topic is we actually started interviewing school mental health teams, and getting their perspective on what they were doing as a school. And it was really interesting having that group dynamic where the team could feed off of each other and like, oh, we're doing that too. Oh, yeah, we forgot about that. And there was one meeting that Andy and I actually sat in. It was like during the height of COVID, so it was on Zoom. And people are snapping at each other over the Zoom when people are sharing stuff, what they're doing, and putting up the heart emojis. We like needed a minute after that meeting to just be like, oh my God, what did we just witness? That was incredible. What a team. And for them, it was sharing stuff like, well, we knew from the first things we had to do in promoting school mental health is we had to establish a school food pantry. Because if we didn't have food security figured out within our building, we couldn't begin to think about how we're supporting student mental health. So it's just really interesting ideas, and that they were able to then feed off and talk about the different strategies that led from that I think just helped people to really think about, well, maybe I have something to contribute because I'm part of a broader team that can comment about what we've been doing together.
I'll also chime in and just say, I think one of the big takeaways, I think to your point, Erin, was also around terminology. And one of the salient points that stuck out for me from our winners experience, I'm sorry, I keep calling them winners, but was just around, our project was really focused on equity, and we kept using the terms like anti-racism, and one of our questions that we had planned to ask was around that. And someone said, what is that? I have no idea what you're talking about. And so as academics, we use language around things like gender expansive, right? And gender inclusivity. And for other individuals, that's meaningless, right? It doesn't maybe promote what we're hoping to inquire and ask about. And so that was really helpful in the early design process to hone in on like, are we going to get the feedback we really want? We need to have at the table based on how we're asking the questions, and the terminology, like we think as academics is important, looks much different to practitioners. And I've heard that common theme today, but was just something that stuck out as part of this work.
I'll just add one point to that as well. I think one theme that came out sort of across the groups was the need to further integrate mental health care and support in a way that increased access, while at the same time, kind of reducing the siloed nature of services. So to the point of what would happen if we do nothing, many families that we spoke with were in crisis actively in some cases while we were talking with them. Because the disconnections across the community mental health provider and the school were so extreme that it was leading to kind of an acceleration of problems and increased intensity of concerns. And so I think the need to sort of move towards more participatory partnership-centered and integrated approaches was a real common theme that came out of the conversations that we had.
Maybe take some questions from the audience. Yeah, Dr. Brown. Microphone's going to be passed around.
Thank you very much for sharing your work. It's really interesting. I am curious about this tension with user-centered design, where the people who show up to help you with the design are actually we're designing for the joiners or the people who are showing up. So when I'm thinking about Aaron's slide, where it's like usability really matters more when we get to scale, and we're thinking about, the user isn't you, but actually usually the people when we're doing, I don't mean to say that this is your experience, but in my experience, when I'm trying to do user-centered design, the people who show up are different than the people who don't show up. And so I wonder about the equity implications and sort of like if you could speak to that and that tension and how your teams have navigated those tensions, or advice for how my team might.
That's a really, really excellent question, and a question that I'm really grappling with in another project. We're also trying to use a co-design process to address vaccine hesitancy with another project that I'm working on. Oh, and actually with Andy. That's funny. And really thinking about doing co-design sessions, but the people who come to talk about vaccines are not the people who are hesitant about vaccines, and they're certainly not going to come and talk to people from UW-Madison about their, so it's difficult, right? We're really thinking about, haven't solved it yet, so I don't know, but we are working with community partners to identify people who fit that. We're looking for people who are vaccine hesitant. We really aren't looking for anybody who's already sold and going to tell me about their neighbor who's vaccine hesitant, because that happens a lot. So we're using our community partners who are interacting with people and Head Start, or, so they know these people and are going to be inviting them. And then we're just going over our focus group guide, and we have to change all of our language to be more neutral. How judgy are we, Automatically, it's just all over the place in our first draft of our focus group. So it's hard. It's a hard question. The answer. I don't have all the answers, but I'll tell you how it comes out.
Sure, I can offer a few thoughts on that point as well. Similar to some of the points we mentioned, I think we're still working, on this as well. I think one thing that, echoing Susan's points, was community partnerships and school district partnerships. I think the extent to which, if we were trying to reach and talk with school mental health professionals, the extent to which, we could talk about our interests and our desires through our kind of district or school teams, who could then reach out to, other individuals, and then, similar working with family oriented serving or advocacy organizations who then reached out to family members, about our project. And then when we talk with families, then families would reach out to other families. It was those kinds of connections that I think really allowed us to talk with individuals who we might not have had the opportunity to speak with otherwise.
On another project, to speak to the challenges sometimes associated with that type of thing, we had wanted different focus groups of teachers, school mental health professionals, parents, and we were like, okay, we're gonna do our best to get parents. It's usually a little bit easier to get folks in district. We got a bunch of parents that responded like, this is fantastic. And we started off with introductions on the focus groups, and for a few parents said like, hi, I'm a parent. I'm also a teacher in the district. And we're like, so, okay, we have a lot of teachers. This is really cool, but it was just another challenge. The people that show up are the people that are interested in this, right? But those strategies that Andy mentioned have been super helpful.
One thing I might add to that is that part of this is the reason why it's so important to really clearly articulate who your users are and who your subgroups of users might be. And subgroups of users might be defined based on attitudinal characteristics. You know, it doesn't necessarily have to be like exactly who they are or what they look like or where they live. It can also be what they think and what they value, and that those can be really meaningful subgroups. And, you know, as Stephen was just saying, different groups of users are not always equal in terms of how easy they are to recruit into a process. But if you have them very clearly articulated, you can at least know how well you're doing relative to the recruitment of particular user subgroups. And I'd also just like to draw a parallel between this and implementation science, where, you know, often when we talk about things like organizational readiness or different things like that, we end up inadvertently or otherwise working frequently with armies of the willing, who are not necessarily representative of other sorts of organizations. I mean, that's part of why in a lot of our work, we've really tried to downplay or eliminate sort of organizational readiness as a prerequisite to participation, rather than simply as like a covariate or something we might even target with an implementation strategy. Absolutely, yeah, proxy for resources, frequently.
Yeah. Okay, we got time for one more question.
First off, I'm loud with this. First off, I wanted to thank both groups of presenters. It was very, very interesting, both of your presentations. I recognize the value of having representatives from different user groups involved from the very beginning when you're developing an intervention. But here's my question. Is it a violation, so to speak, of user-centered design to possibly have done an intervention and then wanting to implement some of the methodology to have these groups now represented? You've gone through this, and I work with school teams. You've gone through this, and now, you know, we'd like to now get your input in terms of what we might do differently to better address the needs. So is that a violation to apply these principles at that point?
I mean, I wouldn't necessarily say so. I mean, depending on what kind of feedback or what sort of thing you're looking for feedback or user experience surrounding, it might require different levels of engagement with the thing. Sometimes you can do that in a 1-hour session where you bring someone in, present some scenarios to them, and there's a good enough sort of sense, and you can approximate what a real world experience might be like. But there's also things that you're likely going to miss that might only emerge over time or with really intensive work with a particular intervention or whatnot. So I think sometimes you might get a different set of information. You'd likely get overlapping information, but I think you could also get pretty important information. There's often this sort of implicit or explicit assumption in a lot of human-centered design, or at least usability testing, that what you're testing is first-time use. And a lot of that comes from digital technologies and things like that, where they want people to be able to just pick it up and run with it. And some of that translates and some of that doesn't always translate when you're talking about these complex psychosocial processes that we're often interested in implementing in health and mental health and related spaces. So I think I don't think it's a violation, and I think it can, you know, garner you some good information as well.
Other input from the panel on that question? Okay. Well, I want to say thank you once again to all of our panelists for this session.